I chose this topic because it's not a topic that many of the registrars may be exposed to during their training, and it is one of the topics in the curriculum that may be assessed during the FRCS. So what I thought the way to kind of structure it is in the beginning, didactic information giving, and at some point try to discuss a case like in an FRCS exam and make it interactive, and let's see how it goes from when that point comes across. I appreciate there's a reasonably good number of attendees. So I'm a new consultant ENT head and neck surgeon. I am working in East Kent Hospital. So greetings from East Kent. It's based in the southeast, cares for about 800 population, and it's made up of three main hospitals and two smaller ones. So on the left side, William Harvey Hospital is where the main hub, main ENT and head and neck services is run. This is the middle one, the Kent and Canterbury Hospital, quite a nice historic hospital with a lot of history. And on the right side is the Queen Elizabeth Queen Mother's Hospital based in Margate. So it's quite a wide geographical area we cover, and that brings in a lot of pathology for sure. So I'm recently finished my training, and for the trainees in the audience, I would say enjoy your training journey. It will finish fast, trust me. So I started sort of my parathyroid surgery exposure back in Addenbrooke's in Cambridge when I was a core trainee, and then followed by Peterborough in the East of England Deanery. And then I had exposure to parathyroid surgery as a junior reg in Medway Hospital, and then where I am now as a consultant in William Harvey. And I was also trained by a general surgeon in parathyroid surgery in Brighton. And also had some experience at Guildford and at East Surrey in Red Hill. And for those from Guy's and St. Thomas's, you recognize this building where I had my fellowship finished recently. I'm grateful for Mr. Pius Journey, who's one of my trainers in the early stage of my career, for some of the information in the talk that I took from one of his recent talks. So what I will cover, so this is what's in the curriculum for the ENT and the general surgeons trainees. So these sort of curriculum through the British Association of Endocrine and Thyroid Surgeon, they wanted to put them together so that it reflects the curriculum. So I will really just very briefly touch on the anatomy, embryology, and pathophysiology, because you can read this from any textbook. But what I will talk more about is the assessment and treatment of the disorders of the parathyroid gland, diagnosis, and that's biochemical and radiological, some operative management and some tips and tricks that I've learned during my training and I'm still continuing to learn, and post-operative management. And that will be helpful for you in the exam as well as in clinical life. So there are usually 4 glands of parathyroid. Less than 1% can have 5 glands. It is a small, so this is here in this picture. I don't know if you can see my pointer, but this is the instrument pointing you to a normal parathyroid gland. It is 2 to 5 millimeter in diameter and 30 to 60 milligrams in weight. So it's a small thing that you're looking at. It is derived from the 3rd and 4th pharyngeal pouch. And the way I remember them, they were inversely. So the superior one's actually from the lower 4th pouch, and the inferior parathyroid is from the 3rd pouch. And this has a clinical importance because the inferior parathyroid has a longer distance to travel to where it will eventually settles at birth and in the adult life, and that makes it more likely to be in an unpredictable location and higher percentage of ectopic in nature. The parathyroid gland is made up of chief cells and oxyphil cells. So the chief cells, as the name suggests, are the main chief cells that produces parathyroid hormone. And the oxyphil cells really have an unknown function that we know of. Now, this is a good, the one here is a nice picture in terms of the anatomy to remember. This is sort of in the coronal section. And if you can imagine that the inferior parathyroid is usually medial and anterior to the recurrent laryngeal nerve, and that has a sort of surgical importance as well. and then the superior ones are usually posterolateral to the nerve. So this is a good picture to keep in your mind, particularly for the trainees. Okay, what does the parathyroid gland do? So this understanding the physiology will be nice to know when it comes to pathophysiology, so you can understand when you're doing the investigations. So its main function is in the calcium and the phosphate hemostasis. In this paragraph here, when you have low calcium detected by the parathyroid gland, it results in the parathyroid hormone production, and that has effects on 3 organs. So it's on the bone to increase the calcium and phosphate release through osteoclast resorption of the bone. On the kidney, where it increases the reabsorption of the calcium and reduces the phosphate reabsorption. And then on the small intestine, where it increases the absorption of both. And the function of that is try to normalize the calcium level. On the other hand, in relation to the phosphate, what the net function of it is results in, when you have hypercalcemia, particularly, it results in excessive phosphate loss and therefore hypophosphatemia in the blood. So these are the main messages, is that it does have an impact on the phosphate, and that's important to look at when you're looking at the blood test. Majority of the patients that we pick up are asymptomatic. They have a screening blood test either for very generalized symptoms, they pick up hypercalcemia, and that is how we pick the problem. Now, when you have hypercalcemia in an exam, try to categorize what are the etiology for that. So though in my mind, I categorize it into parathyroid related and non-parathyroid related, okay? The end organ failure presentation can happen, and I've just operated on a lady who has got really severe osteoporosis, so has got skeletal issues and therefore risk of fractures, and also can present with renal complications. With regards to anyway, when I get asked a question about how would you approach this scenario, start by history and examination. And I do ask about the sort of medical school mnemonics of stones, bones, moans, and abdominal groans. Stones that can be either in the kidney is one presentation. Bones when you have osteoporosis and fractures. Moans, these are the generalized symptoms that can be fatigue. Some patient describes sort of lack of concentration and foggy head. And in really severe cases can be with coma and psychosis. And I had a patient with psychosis present with secondary to hypercalcemia. And abdominal groans, particularly for the general surgeons, relevant here, they can present with peptic ulceration and cholelithiasis. So it is an important sort of findings to try and elucidate when patients come in with very vague symptoms. And it also can result in cataract and some ECG changes. So biochemically, the way we can differentiate between parathyroid related versus non-parathyroid related, in the parathyroid, you will get the hypercalcemia, you get the hyperparathyroid hormone, and you get, as a consequence, because of the physiology that I showed earlier, you get hypophosphatemia in the blood. On the other hand, when you have a hypercalcemia secondary stage, for example, cancer, and that causes hypercalcemia because of a negative feedback, then you get low parathyroid hormone and high phosphate level. So that's a good one to try and remember for the trainees, how to differentiate between the two. So when the patient in the clinic, you've taken a history, you examine their neck. In ENT, we have access to the vocal cord, the flexible nasal endoscope. Now we do a vocal cord check, although that is less so during the COVID pandemic. And the tests that you want to request, majority of these are kindly done by our endocrinology colleagues here locally, because of whether we get the majority of the referrals. But what we want to check is the calcium, the parathyroid hormone, and the phosphate for the same reason. Now, most importantly, what you also want to make sure that the patient has got 24 hours urine calcium. What you would expect with primary hyperparathyroidism is that they will excrete that calcium in the urine, and therefore the urinary calcium should be elevated. And I'll talk about an important condition that you want to make sure that the patient don't have it by excluding this condition, the familial hypocalciuric hypocalcemia, by requesting that 24-hour urinary calcium. And also vitamin D, because vitamin D toxicity can cause hypercalcemia. Now, the radiological investigation, really what you want to try to do is to localize the adenoma, because if your treatment will be very different. If you have a localized adenoma, it's a very short operation. And today is really a parathyroid day for me. I had 2 parathyroidectomy earlier today, and they were both nicely localized, made it a quick 15-20 minutes operation. If you don't localize it, then it's a different ball game, very different operation. So you can see the multiple radiological scans that you can do to do this. That kind of tells us at the moment the sensitivity of this is variable. That's why you have so many of them. But in my practice at the moment, and depends on what your sort of radiological colleagues are comfortable with, I use an ultrasound scan and a MIBI scan. But in the past, in other units, I've used SPECT CT, also 4D CT scan for those cases that are not really localized by the format investigation. And more recently, there has been a talk about the choline PET CT as a more sensitive radiological nuclear medicine test. Right, so the bulk of this talk is about primary hyperparathyroidism, and the majority of the patients are related to a sporadic solitary adenoma. So about 80 to 85% are of that. About 1 in 4 in 1,000 is the reported incidence. So this is just a picture from one of the earlier today from the cases that I did. And this is my finger, so to orientate you: superior, that direction; inferior, that direction. That's the right side of the patient. That's the left side of the patient. So this is a superior flap, inferior flap. I'm medializing the trachea with my finger. And this is the parathyroid adenoma, which was nicely localized on the MIBI scan. Now, about 10% have multiple adenomas, so more than one adenoma, and 5% are secondary to 4-gland hyperplasia. Very rarely, I've seen 2 cases in my training, less than 1% is secondary to a carcinoma. Okay, now, like I said, the bulk of it are related to solitary adenoma. However, don't forget the genetic syndromes, which can account to about 10% of the cases that can present with primary hyperparathyroidism. So the MEN1, these are the multiple endocrine neoplasias, 1 and 2A. The way I remember them from medical school, MEN1 are the 3 Ps. So the parathyroid, the pancreas, they get pathology in that, as well as the pheochromocytoma. The MEN2A is the 2 Ps and the M. 2 Ps are the pheo, the parathyroid related, and the medullary. Also has been syndromic here is the PTH related jaw tumor syndrome, where they have a tendency to get fibroma in the jaw. And like I mentioned, make sure either the endocrinologist or yourself rule out familial hypocalciuric hypocalcemia, because this is not a surgical disease. You'll be doing a patient disfavor by doing a parathyroidectomy in those patients. Now, for those rare cases where you get really high parathyroid hormone and really high calcium, do consider them to be discussed in the thyroid and parathyroid MDT, and consider a genetic referral, because the only way you're going to pick up these things is by looking for them, the genetic syndromes. So, radiological imaging is the main aim is to try to localize the pathological gland. And you can see these are some of the reported sensitivities in the literature. In my practice, I do 2 investigations to see if there is concordance for them between them or not. So ultrasound hand in the very much an operator dependent and in the good pair of hand can be up to 96% sensitive. And again, the same true is for the system MIBI scan. And the concordance rate with them that's been reported in that study by Espinal et al. Is between 32 to 58%. Okay. During my time in Peterborough, I looked at the SPECT CT, and the sensitivities for that was around the 80% mark. The CT and MRI, again, is used for a cross-sectional study to look at the anatomy as well as the physiological study in nuclear medicine. So with CT and MRI, again, I reserve them for non-concordant study. And the same thing for 4D CT scan, where the fourth dimension is time. This is quite a high contrast study, so therefore be cautious with renally impaired patients. And more recently, the Choline PET CT scan, a recent review highlighted Preop of up to 96%. Now, this is a fairly good sensitive study, but not very specific. In one of the studies, I mentioned it up to 13% specific. That is true negative, akin to what you find in the FDG PET CT in cancer, sensitive, but not very specific. So these are just some examples of the study. So this is an ultrasound scan, and here what you see classically is a hypoechoic lesion consistent with a parathyroid adenoma. This is the system MIBI subtraction scan, where the patient ingests the iodine to highlight the thyroid and the parathyroid, and then they get IV administration of the technetium 1999 system MIBI. So again, that highlights the structures, including the parathyroid adenoma. And when you subtract that, after time as you're subtracting the iodine contraction, then that shows you nicely highlighted the adenoma. And this is one of the earlier cases that I've done today. This is a SPECT CT scan where you combine a nuclear medicine functional scan as well as an anatomical scan. And this is here showing you a parathyroid adenoma and ectopic one. This is what you will get with a 4D CT scan. So on the left-hand side, you see a non-contrast study, which shows up the thyroid and the adenoma, where the arrow is pointing to. This is the arterial phase, where it is highlighting the adenoma, and this is the delayed venous phase, where again highlighting the adenoma. On the Choline PET CT scan, this is sort of the picture we used to see in cancer patient. But again, this is showing an avidity of choline highlighting the parathyroid adenoma. So I hear you asking, what is sort of the sensitivity published in the literature? These are really the sensitivities. So in 2006, we were we're beginning to use 4D CT scan, and that's a study showing 88% sensitivity versus 65 for the system MIBI versus 57 for the ultrasound. And between brackets are the localization onto the quadrant. So that's superior right, inferior right, superior left, inferior left. You're trying to, which quadrant is the adenoma. Again, most of these studies show sort of more superior sensitivity with 4D CT scan. And this is a recent study by Amado et al. Of 29 patients, and that showed the Choline PET CT to be more sensitive than the 4D CT scan. So it's an interesting one, Choline CT. Locally, what the nuclear medicine physician is very keen on that, and we're beginning to sort of experiment on that at East Kent, but COVID slightly slowed things down, but I suspect things will pick up again with regards to this. So you really do your best to try to localize it. If you cannot localize it, then there are some intraoperative adjuncts that you can use to get you intraoperative localization. So methylene blue is being described for many years that it stains the parathyroid. And in Peterborough, a study from there showed that it's stained in 78% of cases. And this is a picture showing you staining the parathyroid adenoma versus the non-thyroid tissue. So I have experience of this. I don't have much experience of intraoperative PTH, being sampling, where you are sampling really the vein, the interjugular vein, or to see which quadrant of this after you've taken the adenoma, or to try and see which side is the higher lateralizing, which side has got higher PTH level. One thing I have been exposed to is intraoperative ultrasound. So we got the radiologist to come in with the patient in the surgical position, muscle relaxed, and we were able to pick up the adenoma in 23 cases with those who had discordant imaging prior to this. What we think the benefit of that, with the patient in the sort of surgical position with muscle relaxation, you'll be able to pick up the adenoma more readily. But you have to be very good friends with your radiologist to be able to give you that time to come to your theater. Other techniques that I've used is use a frozen section to check at the time, have you taken the adenoma or not? Because sometimes it can be, a lymph node can be mistaken for that. And intraoperative PTH check, and I've done that in Brighton, where we check the PTH prior to the skin incision, prior to the excision of what we thought the adenoma, about 5 minutes and 10 minutes. And then what you're looking at, because of the parathyroid hormone has a very short half-life, 3 to 5 minutes, the parathyroid hormone should drop fairly quickly if you get the adenoma. When we get involved in terms of management, so there are guidelines on this. So the NICE guidelines in 2019. There is a medical treatment for those patients who are not fit to have any surgery, and that's in the form of calcium-mimetic drug, cinecalcet. So calcium-mimetic, i.e. it mimics the calcium, and therefore sensitizes the receptors in the hope to try to bring down the parathyroid hormone. And the bisphosphonate, which inhibits the bone density loss and therefore reduces the calcium. But hey, we surgeons, we like to operate, and where do we get involved in making those decisions? So if the patient is symptomatic, then that's an indication to operate. If there is an evidence of end organ disease like osteoporosis or renal complications, then that's an indication to operate. And if you have a raised calcium of more than 2.85. Which operation you can do really depends on your localization. So there are multiple ones, and a few ones that I've been exposed to in my training and do now. So there's minimally invasive parathyroidectomy, and I'll show you a picture of this later on, when you have a localized adenoma to the quadrant. Focused parathyroidectomy, where you focus on the lateralized part of the, depending on your localizing scans, or for glands exposure, i.e. central neck exploration. In the 1990s, the majority were getting for glands exposure, but we moved on to more minimally invasive surgery, and that has got the benefit of shorter stay for the patient, shorter operating time, and in one of the studies I've shown that you can save up to 900 pounds by minimizing that and doing a minimally invasive procedure. In terms of day case surgery versus inpatient, I don't think Beats sort of kind of commit to one. In terms of the British Association of Day Surgery, the recommendation is for those patients who have a low ASA without comorbidities. They do mention parathyroid surgery for localized adenomas, i.e. not for gland exposure, can be considered for a day case. So my workup is that I'll make sure they have a full biochemical workup. Thankfully, majority of these are done by my endocrinology colleagues, but if not, then I do. And one of the things I do make sure at least the patients have done is look for end organ failure. So make sure they do have their DEXA scan to check for radius cortical bone thinning for osteoporosis, because you can treat that. And hopefully the endocrinology colleagues are very good at that. Then I do like ultrasound scan. The benefit of that is it's in the good hands. It's a sensitive study, and also gives me a dimension of the size of what I'm dealing with. Because the other nuclear medicine, particularly MIBI scan, they don't tend to comment on the size. They comment on the site and size, but not the size. So it's nice to know what sort of adenoma size you're targeting. And for example, today I had a 6 millimeter one on the ultrasound scan, and when I went into the neck, there was something which is kind of purple tinge, and it was 6 millimeters. So otherwise it would be difficult to localize something like that without knowing the size. I say here SPECT, but really it depends on your local radiology. If the local radiology are more comfortable with MIBI, as they are now here in East Kent, then I'm happy to go with that. If they are concordant, then you can consider minimally invasive parathyroidectomy. If they are not, and you really tried with the other scans, if you have available to you, the 4D CT scan and the colon PET CT, and you still, then you can consider them for foregland exploration. So just to give you a little bit about what minimally invasive entail, usually it's a sort of small 2 centimeter incision in the skin. You deepen your dissection to go between the anterior border of the sternocleidomastoid and lateral to the straps. You can divide the omohyoid for access if you need to. And then if it's an inferior parathyroid adenoma, then excision without finding the nerve is safe as sort of extracapsular dissection. If it's a superior parathyroid adenoma, then it's safer to identify the nerve and then excise the superior one. In the foregland exposure, then you just need to expose the foreglands and see which one can be the adenoma. Post-operatively, you need to check the calcium and PTH at 6 hours, and the NICE guidelines recommend a baseline PTH before the patient go home. And I do check the calcium in the morning to check the, hopefully they would have normalized by then. So, parathyroid carcinoma, a short word on it, it's rare. It is less than 0.3 of primary hyperparathyroidism etiology. Normally you get very high calcium and large size parathyroid, and it's been described that you might palpate a mass. Also look for a vocal cord palsy once we access the flexible nasal endoscopy, and the treatment for that is really surgical, and you monitor it post-operatively with calcium and ultrasound scan. So that is the didactic part of the talk. Now, let's see how this goes. We're trying to make this interactive, so particularly for the ones who are about to sit the exam, see if they can participate in this. So perhaps Ishan, if you can unmute whoever wants.
Hi, hi, it's Tommy here. I'm now allowing participants to unmute themselves.
Mm-hmm.
The idea is, as opposed to normally we do this with the comments, we actually want people to unmute their microphones and just ask their questions directly if they have one. Yep. And Ali will guide us through, I'm sure, the next steps.
Lovely. So this is my first case as a consultant in East Kent. As a 34-year-old teacher, she was referred to the endocrinology team with fatigue and hypocalcaemia on routine blood test. She also has got a background of hypothyroidism and is on levothyroxine. Okay. So can I ask what sort of biochemical investigations you want to make sure that the patient has had prior or radiological investigation that to complete the workup of the patient? PTH, yeah, by that's very good. That's a good start. Anything else? Any other biochemical test? Okay.
I'd probably go with some renal function tests and calcium levels, serum calcium levels corrected. In addition, maybe some urinary calcium levels.
Excellent. Great. Yep. So you want to do the urinary calcium level because you want to make sure you're not dealing with the familial hypocalciuric hypercalcemia. And just like Ravi Kumar mentioned, also request radiological to try to localize the adenoma. Okay. So ultrasound in MIBI is a very reasonable radiological investigation to start with. So let's have a look. Let's go back into my presentation. So her calcium was elevated at 3. Her phosphate was low. And the 24 uric acid concentration was 2.7, which is elevated. So kind of goes with the picture of primary hyperparathyroidism. And also the other one you can request is urine calcium to creatinine ratio. Again, this makes it that familial hypocalciuric hypercalcemia is unlikely. She was deficient in vitamin D, so that's not related to vitamin D toxicity. Her renal profile was normal. She had an ultrasound scan of the kidney, which was normal, and then she had a nuclear medicine parathyroid scan. So this is the ultrasound scan. So just a little bit of anatomy on this. I mean, ultrasound is a dynamic study, but if you imagine that this is an axial through the neck, if you'd like to think about it like that, so that's the skin on the top of the picture. This is subcutaneous fat, and these are the strap muscles, and this is the trachea, here, and these are the carotid in the IJV. And this is hypoechoic lesion, which is quite large, measured at 5 centimeters. That was noted on the ultrasound scan. And then the MIBI scan, which is a subtraction scan. Now, bear in mind, she takes thyroxine. So therefore, that subtraction component becomes difficult. But if I can convince you, just to say that's on the late phase, there is here an uptake here of the system MIBI that suggests that there is an adenoma in that region. So we went ahead, did surgery for her. It was a large one, it was 5 centimeters. So I went through a central neck incision. And here, just to orientate you again, superior, inferior, right side of the patient, left side of the patient. So this is here, the thyroid gland has been mobilized. And you can just about make up in the picture that the recurrent laryngeal nerve is here. I saw a small parathyroid here, which I thought was the inferior. And this is actually the adenoma. So this was after I excised it. Again, there's another picture here showing the recurrent laryngeal nerve. And it measured just like they did on the ultrasound scan at 5 centimeters. So post-operatively, her calcium normalized, but her PTH plummeted at 6 hours. So, but normally, this is fairly common now, I've seen it with a few patients, is that because of the hyperfunctioning adenoma, you remove it, the other parathyroid gland become hypofunctioning during that period, and they need some time for it to recover. And that's at the blood test at 4 weeks, calcium 2.4 and the PTH normalized to 6. The histology confirmed as the adenoma, and normally you get sort of correlate with biochemical test to confirm it. And that was the outcome. So this is a different scenario. This is not a real patient, just a makeup one. So you have a 20-year-old female with post-operative numbness post-parathyroidectomy for primary hyperparathyroidism. The calcium is now low, phosphate is low, the PTH is normal. So for those about to sit the exam, anybody want to hazard a guess what the diagnosis is?
Hungry bone, basically.
Absolutely. Spot on. Well done, Basim. So yeah, it is hungry bone syndrome, which is one of the rare complications post-parathyroidectomy, where essentially you're taking out the adenoma and the calcium starts to, the bone has become hungry to the calcium. It takes up the calcium, and therefore you get hypocalcaemia. Right, excellent. So I'm glad that the interactive part became interactive, which is good. So just to go back again to what was objective when we started, we've covered the knowledge part, briefly about the anatomy, embryology, and pathophysiology, and you can read more about this in textbooks. We covered the assessment and treatment of parathyroid function, the diagnosis, particularly in relation to primary hyperparathyroidism, some of the operative management, including the principles of surgery, the minimally invasive versus the focused parathyroidectomy versus foreground exposure, and the post-operative management. So my finally sort of summary and tips for you is exclude familial hypocalciuric hypocalcemia in your workup. Do consider the syndromic and cancer if the calcium is very high. Try to localize the adenoma as much as you can. Arm yourself with as much information as you can. Almost put a medical hat on, become a medic and trying to really localize it and look for the potential complications of primary hyperparathyroidism. If you still can't localize it, consider the intraoperative adjuncts and see what you can do locally about this. Now, during the surgery, it's fair to say that you need meticulous hemostasis to make sure that you are not contaminating your surgical field with blood. And look for some hiding places where the parathyroid adenoma can hide in the carotid sheath, retroesophageal, I've seen it, and really have a good look in that side of the neck, particularly where the suggestion is radiologically, and then monitor for hypocalcemia and hungry bone syndrome postoperatively. I hope you found it useful, and thank you for listening, and happy to take any questions.
Thank you, Ali, and feel free to leave that slide up for a minute. We have to take some questions coming through. So the first question from Sarah Timms is the next question of, do you operate on asymptomatic patients who are under 50?
I think if the There are two school thoughts process to this. If it's 2.8, above 2.85, NICE guidelines says you can operate. One of the thinking process for operating is that you want to prevent future complications of persistent primary hyperparathyroidism. So you want to prevent the osteoporosis that the patient will get in their late 60s and 70s. So in a way, as a preventative measure, yes, I do operate on that.
Another question from Aaron Cronin, who was SHO here a few years ago, was about what your preferred post-operative medication for hypocalcaemia is. I think a lot of us have seen BTK guidance with Alpacalstol and Sandocal, but equally commonly you'll see various people using Adcal. Do you have a preference, and if so, why?
Is this in the context of primary hyperparathyroidism, parathyroid surgery, or in terms of thyroid surgery?
I think it's in the context of hypocalcaemia, whether it be from hungry bone after a parathyroid operation or from thyroid. And if there's a difference, then it'd be probably a good thing to explain why.
Yeah, so there recently been some BEATS guidance on this. My thinking prior to a few years ago is I wanted to avoid giving them vitamin D, particularly in thyroid surgery sort of context post total thyroidectomy, is that inhibits the transcription of the parathyroid hormone gene and therefore reduces the parathyroid hormone secretion. But actually the counter side of it is that if you give vitamin D, then you are increasing the intestinal absorption of calcium. So nowadays I do give both calcium and vitamin D as Adcal.
And your preference is Adcal for the calcium replacement?
Indeed.
Yes, I think one of the things is Sandocal's in the BTA guidelines, but a lot of patients find it hard to take.
You don't like the taste.
Good. Do you have any other questions? I think we've. Oh, here we go. So a lot of thank yous coming through.
I do have a question for you.
Go on, Nishan.
Sorry for the late question. From point of view of intraoperative adjuncts, do you have any experience with using autofluorescence of parathyroids?
Yeah, so there is a very, very good recent talk from BEATS about using autofluorescence in the context of thyroid surgery to try to localize the parathyroid gland to prevent inadvertent parathyroidectomy. I personally don't have experience of it. I think majority of this is under sort of research pathway at the moment, but I think this is from a really fascinating talk, and it is something to watch out for the future.
Perfect. Thank you, Ali.